Hello, everyone, and welcome to another episode of Muted in Medicine podcast. Hello, everyone, and welcome back to Muted in Medicine, the podcast where we break the silence on untold stories in healthcare. My name is Saba Fatima, and I'm your host for this podcast. I'm a pediatrician with a passion for helping healthcare workers facing secondary trauma at work, which often they're unprepared to face. If you're liking our content, please subscribe on YouTube and give us a review on Apple or Spotify. Most healthcare workers expect difficult patients, difficult diagnoses, and difficult days. What many don't expect is to be threatened, assaulted, or made to feel unsafe while simply doing their jobs. Today, we're talking about workplace violence in healthcare, how it affects those who experience it, the unique challenges of caring for patients with psychiatric and behavioral health needs, and how we can create safer environments for both patients and healthcare workers. I have with me today Kimberly Urbanek. She's an award-winning workplace violence expert, best-selling author, and nationally sought-after speaker. With over 25 years of clinical, public safety, and trauma experience, Kim is certified as a master-level crisis prevention instructor, International Critical Incident Stress Foundation responder, wellness facilitator, and is the co-founder of Optics, a groundbreaking AI-driven platform for violence and risk mitigation. Kim, welcome to the show.
Thank you so much, Saba. I'm so excited to be here with you and with your audience. So thanks for having me.
Yeah, me too. I've been wanting to cover that topic for a long time, so I'm really excited that I finally got you on here. You know, we ask everybody when we start, what is bringing you joy at work today?
What is bringing me joy at work today? Well, when I see the impact of workplace violence on individuals, our clinical staff, our providers, our APPs, the downtrodden, the erosion that happens after time, and then the enlightenment that kind of comes after we're workshopping, after we're providing skills, after we're creating a culture of safety that prioritizes them, because that message gets so lost, I think. It just is so satisfying because that is really my passion. No one should get injured trying to heal or care for somebody else. And so it's just really, I think, the thing that brings me the most joy in this role.
Yeah. And I ask everybody, what's your story? You know, how did you get interested in this topic and what brought you here to do this work?
So I kind of have a very non-traditional story, I think. I've always been in love with healthcare. From the time I was 3 years old, I was, fishing with my family, and we would catch fish, and then I'd be off on the side, like dissecting them and like looking at what makes them work and run and all of those things. And so I worked on the clinical side of healthcare for many years. I worked in the emergency department, in open heart surgery and ICU. And I even did very raw, I would say, kind of healthcare in the field. So as a critical care paramedic and in 911 response. And so I loved being able to care for patients. And as I was being kind of raised through that clinical education and pathway, I was taught that there's going to be difficulties and upset patients and upset family members. And if you didn't have thick enough skin, you just couldn't do this job.
Yeah.
And so I fully believed that. Well, it's just part of the job. It's part of being resilient. It's expected. And I was always very interested in emergency kind of response. I felt like I've been really in my element when things are chaotic and pressure filled and stress filled, because I liked to create the calm.
Mm-hmm.
And so that really filled me up, especially in the emergency room environments. But I very non-traditionally kind of transitioned then into the opposite side, non-clinically. I got more involved in emergency management, disaster preparedness, and then public safety ultimately, working as a public safety officer and leader and manager and then director. And it just was not the trajectory that I would have expected, but it was a really unique intersection to be able to have the clinical experience and the clinical lens coupled with the expertise of safety and emergency response that I felt so many people didn't know and didn't have information about. And so it framed my current position, in the sense that I have been educating and training on this really my whole life. And so formalizing that and creating practical approaches for clinicians who are prioritizing others all the time and never get the message to prioritize themselves. And so I think one of the things that is just innate in caregivers is putting other people's needs before ours.
Mm-hmm.
And so from the clinical perspective, I think there's so much we can talk about, but we normalize so much of what's going on because of the disease pathology or because of the healthcare process and systems.
Mm-hmm.
And so I think that's kind of how I've gotten to where I'm at. And I just dove in, jumped in with both feet and really studied neuroscience behind conflict and trauma-informed approaches and resilience and the effects of workplace violence. And so it became a specialty area for me and an area of expertise that now I'm blessed to be able to share nationally and internationally. So.
Yeah, that's awesome. Was there an event or incident that happened to you at times which really affected you that you can remember?
I mean, there's hundreds, of course, honestly. I can't be in healthcare for 25 years in really one of the most high risk areas and not have incidents. I've been at facilities where we've had shootings and where we've had traumas and where we've had literally, I don't want to trigger anybody, but literally, having to remove a child from a mother's arms to hand them over to a DCFS worker. You don't always realize the impact on the workers because in the moment you're so concerned about the individual. So that results in violence. It results in lots of high emotions and embedded memories. And so, yeah, there's hundreds of them.
Yeah. And, it seems to be increasing now in healthcare, or maybe it was always there for a long time and maybe we started paying more attention to it. But why do you think this is happening in your research and your work?
So I think it's always been there.
Yeah.
I mean, like I said, I'm kind of old in this field now, and I know that I had it growing up through the field. And I think there's some complexities about why it's happening. But I will say that we've seen a shift in our culture, in society, and in awareness of the problem and the expansion of the problem. Healthcare workers are now 5 times more likely to experience violence. 5 times more likely than any other industry, which is staggering. And I recall when I first started working in healthcare and getting involved in this kind of work, it was twice as likely. Then 3 times, then 4 times, and now 5 times. And so I continue to see it grow. And maybe it's getting too late to kind of go back to this, but I deeply believe that the COVID era, we absolutely saw this shift in society, in societal demands on healthcare, in expectations, in how we navigate the broken systems of healthcare, and just in the way that we have this immediate need for gratification. We come in expecting a certain pathway or outcomes or medication, and the healthcare system hasn't really updated the way that society has. And so we've always seen violence in our behavioral health settings or in our emergency departments, but now we see it everywhere. We see it in our clinics. We see it at our registration desks. We see it with our greeters at our main entrances. And so it's rampant.
Yeah, how sad. Yeah, and it can be in the form of physical violence, verbal violence. What are the different types of violence that you see or threats?
Yeah, I'm glad you brought that up because there's often this belief that if I'm punching you or I'm throwing a chair, of course that constitutes violence. But if you look at the OSHA definition, the Occupational Safety and Health Administration, they put out their definition, which is really any act of harm or threat of harm, which includes verbal aggression, harassment, retaliation, as well as battery, damage to property, all of those things. And so when you look at that wide umbrella of a definition, a lot more things fall under there that we're not even doing a good job of keeping track of. The verbal abuse. You see a lot more verbal abuse in maybe our outpatient clinics and settings or our ambulatory centers and sites than you do see more physical type aggression as well as verbal in our inpatient settings. And because of that dichotomy, people don't always think that it's bad enough, right? Is it bad? Oh, they yelled at me and called me names. Is that bad enough to report? Is it bad enough to, ban a patient from a practice? No. So we just develop this tolerance to it because we don't name it what it really should be named. And so it's interesting you brought up the types of violence. I always refer to like verbal and physical type violence, but of course there's 4 actual categories that NIOSH, the National Institute of Occupational Safety and Health, put out based on who the offender is. And so criminal type violence is type 1, and that's when the offender is unknown to the organization. Really just somebody using a healthcare or hospital setting for an opportunity for crime or for violence, like jumping somebody in a parking lot. Type 2 violence is considered customer violence, which for healthcare is patient and visitor, family members. That is the most egregious, most voluminous type of violence that we see anywhere, and the numbers do change a bit from year to year, but anywhere from 80 to 83% to, on the low end, up to 95% on the high end, depending on the facility. That is where the huge majority of incidents come from. Type 3 violence is employee on employee. This is not one that we ever talk about as actual workplace violence. We always say, oh, it's an HR issue or a performance issue or a management issue. But technically, it's supposed to be reported as workplace violence. So when we're looking at bullying and harassment and discrimination, those things have a place in this umbrella of incidents, although those are kept really quiet, right? They're only known to a few people in an organization, and they are existent. I bet you can think of somewhere you've worked where you've had somebody that's just a bully to everyone. They're toxic. Everyone knows it. Everyone knows their name. And they still keep showing up every day, and they still keep affecting the department every day. And so that technically falls under employee on employee. There's also ex-employee. So if somebody falls under that same category. So if somebody worked there but left or got fired, but they're coming back or they're inciting violence and have a grievance, that still falls under that same category. And then type 4 violence is domestic violence or intimate partner violence. And when we talk in healthcare, often we talk about domestic violence that's occurring to a patient. We talk about the patient being the victim because as advocates, as mandated reporters, right, we're always thinking patient first. And so it's a caregiver or a spouse or an adult child. However, we don't have the conversation around how our healthcare workers are the victims and how domestic violence doesn't stay at home, it spills over into our workplaces. And so although it's not the highest volume of violence in healthcare, it is the most fatal type of violence. So when we see fatalities at hospitals, statistically up to this point, they have been caused by a domestic partner in many of the circumstances. So a very important conversation, even though it's not the most voluminous.
Yeah. Wow. Yeah. Thank you for, I think that was very good. Just you clarifying how the different types of violence is. And, as you were talking, I'm thinking about a few of the things you said, the yelling, and I'm like, oh yeah, that has happened to me. And I've been kicked out of rooms like so many times, and somebody has yelled at me. So like, that's just like the same mindset, you got to have thick skin, you got to be more resilient. Like, I'd never even thought of that as violence. Like,
Of course.
before you're now saying it, I'm like, oh, okay. And when you talk about the customer violence kind of thing, I think that's the one that we face a lot, just when people are not happy or, with the treatment they're providing. And as you were talking, I was thinking, I've heard so many incidents of people and doctors who were also shot, when
Yeah.
there were, I was just thinking, I can't remember the exact details of somebody who was shot in a clinic or setting when, somebody didn't get the medication they need, or, something like that. So I'm thinking, do you think that over time, like, we kind of allowed it, and if we do allow it, then it can get to a certain extreme, or, should it be part of good customer service or part of being a good clinician? Because you also think about that trauma aspect, right? Anybody who's
Yeah.
coming and behaving a certain way, they have this background, this trauma. I always think about that. I work with pediatrics, so parents who are worried about their patient, like their kids. It's the most worrisome time of their life. So many times I just let it go. What are your thoughts on that?
So I don't want to re-victimize the victims in the sense of saying, oh, well, it's our fault because we just tolerate it, right? But the reality is we do build a resistance to it or a tolerance for it. That being said, we have to understand and expect that people are not in their best mindset. They're not having their best day when they come to us. In an inpatient setting, in an emergency setting, in an outpatient setting, even if I'm coming in because I'm excited to be delivering my firstborn child, the nervous system gets reactive, right? There's actual science behind it. And so the reality is that there hasn't been as much support for us to address it. And we have a task. We are very purpose driven. I have to continue care, and I'm licensed, and I can't walk off the job, and I don't want to lose my job. And I know that I have performance standards and metrics. And so I think it's really complex as to why we quote unquote tolerate it. We've normalized violence. We understand the pathology behind it. We better than most, right? As healthcare workers. And so I think that as society has changed, our culture hasn't changed to transition us to having a personal mindset first, then patient. And we are so now focused on patient metrics, patient outcomes, patient satisfaction, and patient experience, which I'm a huge advocate for and is the goal of why we exist, right? And research now shows that we will never achieve those things. When we have a workplace violence incident, we see all of those things that we say are so important suffer, which I feel like I've known for over 20 years. But now there's actually research that shows when there's a workplace violence incident, when there's not that therapeutic rapport or connection, when there is an escalation or a threat, errors increase, grievances increase, lawsuits increase, outcomes suffer, patients' quality of care suffers because we're navigating our own risk. They're not the only ones that have this emotional reactive mindset, right? Our brains are wired for survivability. Yeah. And as great as we think we are at multitasking, we can't actually function from our prefrontal cortex and our amygdala both at the best at the same time, right? Our thinking brain and our reactionary and survival brain cannot really coexist both in full function. And so we start getting defensive. We start having to try and just get very task oriented. And, unfortunately, we're pushing to do the job instead of stepping back and taking a breath and breathing. And for me, it all comes down to risk assessment. We have not been given the skills or the training to do a risk assessment. We're great at other things, other assessments. You have to be as a clinician. No one walks in saying, this is exactly what's going on with me here, and I've got this and this and this. And so you have to peel back the layers of the onion. You have to put patterns together. That's why you're the doctor, right? That's why you're the expert. We have to do the same with behaviors. We have to be able to determine when a patient is difficult, which we provide care for, to when now they're starting to get disruptive, which we need to start intervening with, and then when they're starting to get dangerous. And so I think when we don't give people the skills to identify, is this difficult? Is this disruptive? Or is this dangerous? We should not be immediately intervening at the dangerous level unless we're in an environment where there's an immediate life threat to the patient or someone else, right? And we don't get that memo. And so we just we're trying to manage the difficult patient. They become disruptive and we're still trying. And now they're becoming dangerous. And we're like, oh, because we haven't been given the skills to really assess that and be empowered to know how to respond to it when it shifts.
Yeah, I love that. Yeah, I agree that we don't feel empowered because we're not really having this conversation at all. Like, I don't think I ever, have had this conversation in such a setting when we're really talking about it's always about, which I get it, about making the patient happy. And, you talked about the metrics and all those things, which I get it. Like, I'm all for it. But yeah, just that piece of preserving some identity, like some safety for ourselves in that aspect. So thank you for highlighting that. Talking about like psychiatric patients, I think the violence is not intentional in that case. And what misconceptions do people have? How can healthcare workers balance that sort of empathy for patients with mental illness, also maintaining their own safety? Because I think that might be a big piece of the violence as well, and aggression.
Yeah. So I think one of the misconceptions is that like behavioral health patients create all the violence. And I know that that's not true. And just for everyone to know, that's not necessarily true, right? Yeah. There are particular diagnoses or particular disorders or addictions where violence is a very closely associated characteristic potentially, especially in crisis, right? So here's the thing. We're not just managing somebody with anxiety. We're managing somebody with anxiety who's in crisis. Right? They're managing their anxiety every single day and they're not violent. But when anybody is in crisis, then add in some of the additional, contributing diagnoses. Mm-hmm. It now becomes even more escalated or even more inflated in the types of ways they can cope or navigate some of the stressors that they're under. So even like neurodiversity or dementia and Alzheimer's or TBI, traumatic brain injuries, the violence isn't intentional with them.
Right.
And it's still violence. And so often healthcare workers only call things violent when they believe there was evil intent. And I think that's a really important takeaway that no, they didn't mean it. Maybe they're confused. They thought it was holding them against their will. They're trying to get out of their room and they're hitting me, and it's still violent, right? And so we have to call it what it is. Getting back to your question, how do we balance the empathy and the compassionate care with safety? We have to use good situational awareness. We have to use good assessment. We can do caregiving that provides all of the connection and comfort and kind of touchy-feely, care that we want to provide. And by adding in the safety layer, embedding that into everything we do every day, we can still then prioritize our safety. So I'll give you an example of this. One of the things I always teach is a well-known concept in the law enforcement and security world as scanning your 360, scanning 360 degrees, right? So what does that mean? That means situationally aware, knowing everyone who's around me right now, and anticipating potential issues. Now let's transition to our healthcare environment. We're all day long walking in and out of patient exam rooms or patient rooms or suites, depending on your facility type. And we're blind. We're so comfortable in our environment, we do it blind. How many times have you walked into a room and you look and you're like, wow, there's a gaggle of people in the corner that I didn't even know were in the room. Why are we surprised? That's a miss on us. No, I didn't see them come in, or no, I didn't see that. Oh, the respiratory therapist is here. I didn't even know that. We need to stop at the door, at the threshold for 2 seconds. You're supposed to be hand sanitizing anyway for 20 seconds before you go in the room, right? So while you're doing that, be proactive, be preventative, pause at that door frame. Don't breach the door frame unless you know what you're walking into. Take 2 seconds and just scan the room. I had a colleague who at one point was taking care of a patient that was getting agitated and escalated. She had been in and out of the room multiple times, and she had walked out to get something, and she walked into the room to go back and care for him. And by the time she kind of walked in, she was already several feet into the room and realized he's not in the bed. And it took her a second to look, is he in the bathroom? And he wasn't in either place. He was behind the door, planning intentionally. So when she walked in, he slammed the door behind her and came up to assault her from behind. Now, I don't share that to be paranoid or to be triggering, nor to provide any sort of harm or blame to the individual. Wasn't her fault. And it's 100% preventable. 100%. If I stop at the threshold and I find something in the room before I walk in that could be harmful, I'm not going in that room. If I see you behind the door frame, I'm not walking in. I'm stopped. Why are you behind the door frame? Go have a seat, or I'm not entering. So I don't want to oversimplify it, because workplace violence is a complex issue. But that's just one small thing that actually empowers us. Our safety is a priority. Then make sure I'm okay for patient care.
Yeah. So you're saying that in all instances, or in majority of the instances, it can be preventable. Is that a true statement or no?
I won't say in all instances. That would be foolish for me to sit here and say we can prevent all violence in the world. No, I'm not saying that. A huge majority of it, a huge percentage of it, in doing countless amounts of root cause analysis and apparent cause analysis and investigations and incident reviews and, interviews with people that were involved in circumstances. There's a lot that we can do to fix the system and or allow the caregiver to pause and disengage or step back to create more of a team response, or to brainstorm quickly what can be done. We will forever get some of those patients, like I said, where they're just not in their right mind and they're in a crisis or in an emergency and there's potential violence. Absolutely.
And
But
they may
that's
be
not
self-harming, yeah. Right? They're self-harming too. Like that's when you want to go
absolutely.
in and intervene. Yeah.
Yeah. And so violence isn't typically one explosive event. There are characteristics of escalation that we don't teach in our nursing schools, that they never have a class on, and that we throw them in the environment and then we expect them to be experts. No, by the time, you're up to your knees is too late. So that's always been one of the things that, coming from a clinical background into the public safety, law enforcement, security kind of role, always shocked me and frustrated me, was how reactive we are to violence. Safety and security and public safety is considered an afterthought. This happened and now I have to call the police. This happened and I have to call somebody to come and medicate or restrain the patient. It happened and now I have to report it and file it. That's too late. That's too late to be concerned about it. It's too late to start doing something about it. Of course, we need to have a solid response plan. But what are we doing before it gets to that? What are we identifying in the tone, in their escalation, in their body language, in room positioning that is creating additional blindness that we just keep caregiving? Oh my gosh, now it happened. There were signs. And
Can you
so we don't
elaborate on that? Go ahead.
sorry.
Sorry, I was gonna say, can you elaborate on that? Like, what early signs of escalation, like, and for nurses, because I think they're at the forefront of a lot of the violence because they're at bedside a lot. It might be too simplistic, like that question, if I'm asking, because it's a
Yeah.
variety. Hmm.
So I think some of the characteristics or the signs are simple to add, right? I mean, they start to become obvious when somebody is raising their voice, when somebody is yelling, when somebody is. So again, getting back to that risk assessment of transition. So what does difficult look like? Maybe resistive, maybe pushback, maybe loss of control is creating. In fact, I know loss of control is one of the major reasons people are escalating. When that starts to transition to like, this place sucks, you guys don't know what you're doing, blah, 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 to you suck, you don't know what you're doing. Now it's a little more targeted. Now it's a little more intentional. And so we kind of characterize and lump a lot of those things in the same bucket, but there's a shift. The same sensitivity that we look at disease pathology with, we have to also look at behaviors with. And I have to also say, communication skills in healthcare. It is my lived experience and my opinion that we know how to professionally communicate, but we are egregious at being conversational narcissists. And what I mean by that, that's a word most people don't know, but they've all experienced it, right? Conversational narcissism is when we are constantly changing the focus of the conversation to something we need and want.
Mm.
And instead of actually listening to what they said and acknowledging or responding to the very thing they said. So they could say, I don't want to be here. And you go, well, it's best for you to be here because we're going to take good care of you. We're on total opposite sides of the spectrum then. I don't want to take that medication. Well, this is the medication that's going to help your blood pressure. You have to take this one. I don't want to wear that gown. You have to wear that gown so we can go ahead and get the x-ray and examine you. We are in this hierarchical profession. And by design, it's very authoritative.
Mm-hmm.
What other business or industry do you walk in and we say, give us your clothes? No, you can't wear what you're wearing. Put your water down or your drink down or your food. Nope, you don't get to eat anything until we tell you. Nope, you don't get to have any visitors until we tell you. Nope, you don't get to leave the room until we tell you. Like, hold on. We know that we're doing it with good intentions and because we know what's best. But all that is received as loss of control, loss of certainty, loss of comfort. And that triggers me to be defensive. You're an enemy. That feels threatening.
Mm-hmm.
So I'm going to push back. I'm going to fight you. We have a human need to have some autonomy. And in healthcare, we strip everyone of the autonomy. We can't even provide access to healthcare. It's dependent on what insurance says or what the doctor says or
Mm-hmm.
what location we say you have to go to. Where's the autonomy?
Mm-hmm.
And so it feels extremely suppressive and we get defensive from the get-go, just by design. Now, that's no fault of the workers, of the staff, the healthcare workers. And we believe also, I think that we hold this kind of belief that, well, they're just not making good decisions. If they knew better, if they knew what I know, they would make the right decision for them. And so we keep pushing our agenda. We keep pushing our message. Instead of saying, when someone comes in and is like, I've been waiting for so long. And, if I'm late, the doctor charges me. But if he's late, I'm just waiting 2 hours and my time doesn't matter and blah, blah, blah. And what is the immediate staff response? Defend it. well, the doctor got called for an emergency and we're trying to see you as soon as possible. And if you can have a seat. And okay, we just ignored everything they said. We just told them what we need and what we want.
Mm-hmm.
They told us what their concerns were. We didn't listen. Instead of saying, oh my gosh, well, please understand and just be patient, which is kind of what we're trying to plead with them for, we should say, wow, you have been waiting a really long time. Wow, that must be really frustrating. I bet you had other things planned for the day. You didn't plan on being here that long. I'm sorry.
Yeah. No,
and then go into our explanation. And then we have to meet them where they're at in order to pull them to where we need them to go. And that requires trust. It requires trust.
No, I mean, you're right. You're right about a lot of things. I think that does happen. And is there some basic de-escalation techniques that can be of educational value to whoever is listening, somebody who's maybe at a basic level too,
Sure.
starting out? Mm-hmm.
Well, one of the simplest and very successful ones is validation. And kind of going back to what I was saying, conversational narcissism is about changing it to be what I want and what I need instead of validating what they're saying. And so one of the things I like to try and share with people is I don't have to like what they said. I don't have to like how they're feeling. It's their feeling. I can't try and course correct that. I can't try and change their mind. Not when they're, reactive and they're upset and they're expressing feeling. All feelings are okay. All behaviors are not.
Mm-hmm.
And so if we want to calm the feeling, we have to make them feel heard. It's a basic human need of that Maslow's hierarchy of needs, right? Of feeling safe and secure. And if you don't hear me, I don't feel safe with you. And so really true validation, I see us get this wrong all the time. We say, I understand, but here's what I need you to do. I understand, but explain, data dump. Here's why you need to do this. Here's why this is best for you. They're not there yet. And so true validation is summarizing back what they just said, giving some emotion on what they just said, allowing them to kind of quiet that reactive piece so that we said we can't multitask with that, right? So that that logical piece can receive the great expertise and care that you're trying to convince them to take. And so validation sounds like not I understand. That's my frustration. It's not about understanding. No, you don't. Oh, you understand? You understand what it's like to wait here for 3 hours? You understand what it's like to be sick and puking? You understand what it's like to have no way to go back to work because I can't, whatever is going on with them? Why do we say we understand? No, we don't. We're just basically saying, I got it, but still we're going to move forward. And so if we can be reflective on that, are we conversational narcissists? We know what that feels like, right? When we've had something happen, like maybe we've had a bad day and we're like, oh my gosh, I've had the worst day. I just need to vent. I'm going to call that person, right? Whether it's my friend or my spouse or my mom or whoever. And we're like, you would not believe the day I had today. It was terrible. Oh my gosh. And when they say, me too, let me tell you what happened first. Hold on. Listen to this. You will not believe this. Conversational narcissism.
Yeah. And it's very common, I think, amongst everyone. But I think recognition is important. I think we have maybe 15 more minutes left into the conversation. I want to cover everything that I wanted to ask you. What impact does healthcare violence can have on healthcare workers? We talked about burnout, the moral injury piece. I think when we talked offline, I was talking about when I had incidents at work, when I saw that nurses were being attacked by one of the patients that I was caring for, it felt very wrong to me, and almost like I had that, survivor's guilt where the nurses got hurt. I didn't, because obviously I was in the background. So I think there's a lot of trauma to that. And then some actionable points of how we can prevent as an organization, as individuals, kind of bring this needle down on this workplace violence that's affecting healthcare workers.
Yeah, so there's more and more information coming out around the impacts of workplace violence. I think
Mhm.
we've known that
Mhm.
some of it for a really long time, besides like the burnout and turnover and the moral injury and the just self effacing approaches that, oh, should I have done more? Should I have caught this sooner? Oh, maybe I should have done something different, right? We instantly turn inward and kind of self blame in a lot of those circumstances. And we are seeing, especially with our newer generations of nursing and healthcare workers, where they're like, I'm not going to be treated like this. It's not okay. And we're seeing a mass exodus from the nursing profession. We're seeing high suicide numbers with physicians. We're seeing ongoing trauma in healthcare workers that are impacting not just themselves, but also patient care in the industry at large in a time when access to healthcare is already critical in so many places. We're seeing funding cuts and just compounding of hard to stomach conditions to work in. And it starts with the organization. It starts with the organization calling it out, prioritizing. I'm not going to be able to solve American healthcare, you know, and insurance by myself here, right? I don't have all the answers for that. And we can't just keep stomaching it and expecting the frontline teams to absorb it. It's too much. It's relevant in our industry. We are now seeing nationally uh, leaders and charge nurses with less than 2 years of experience.
Yeah.
We've lost years of expertise, and 2 years is not a long time. I mean, I'm sure you could speak to where you were at in your first 2 years of practice. You're like, okay, I'm just starting to feel a little bit comfortable. I'm just getting my feet wet. Now we uproot you and say, now you're in charge of entire units and hundreds of people, or at least tens and 20s of people working on your shift with no other administration here on weekends, overnights, and you manage everything. That is a broken system. And so what are some of the things we can start with? I think it starts with support and empowerment. It starts with tough conversations without being defensive. It starts with rounding and normalizing conversation. First of all, sitting down and having conversation with your teams. I do a lot of consulting nationally, and it's always interesting to me. They don't know me necessarily, right? The staff don't know me. I can walk into an organization, we can do a focus group, we sit down, or I go to a unit, I just spend some time and I just listen. I say, what are some of the really unsafe things in your unit? And they tell me. This door has never locked. Everybody keeps coming back. Everyone feels unsafe about it. Okay, thank you. Start having conversations, start actually hearing physicians and staff, and then care enough to do something about it. You cannot say, oh, I care about you, but we don't have budget for this. This is the cost of doing business. We have to invest in staff. We have to invest in providers, or you have no team. And so when it gets hard, we have to stand by our staff. So I'll tell you, I'll give you a quick example. You might have a family member that's extremely disruptive, extremely abusive. And finally, it gets to the point where leadership and staff and everybody are on the same page. And we say, you know what? This person is banned. They can't visit anymore, or they can't come to appointments anymore because they're too abusive to staff. And then something happens, or the patient's hospitalized, or they're having an appointment, and they're like, well, I'm the POA. I'm the power of attorney. And so then we go, oh, well, okay. And then we crumble. we do not model how to set limits and boundaries that we will not shatter. I'm not saying we have to be inflexible, because things have to be looked at on a case by case basis. However, what did you just do to that staff person? You just said, it's hopeless. There's nothing that anyone could do that will make us actually stand by you. So we've just embedded even further that, well, this is just the job. You have to take it. The same thing happens when we don't involve our physicians. So think of the clinic setting when the front of house, right, our registration or our roomers or our MAs are really running interference with the public. The back has no idea what's going on in the front, and vice versa.
Yeah. Yeah.
And they come in their worst mood, and their lowest paying frontline people are the ones holding the line and absorbing all the abuse. And they're like little angels sometimes to the physicians, and they're terrible to the staff. Is that being addressed? Do we have a protocol where the physician says, hey, glad you're here today, Joe. Before we get started with the appointment, I heard that there was some upset that happened in the front. Can you tell me about that? What was going on? Thank you for telling me what your concerns were. I understand if we messed up the schedule or that you had to wait long. That wasn't their fault. It was mine. And I just have to let you know, we're not going to tolerate that kind of behavior to anyone on our team. So we're happy to care for you today. But I want to let you know, if that happens again, we're not going to be able to continue to see you. That's life-changing to the staff. Cohesion within the team, saying, I don't care who you are, even though it didn't happen to me, I'm not going to let it happen to somebody else on my team. Consistency is what builds expectations. Consistency is what builds support and empowerment. So that's such a intangible thing that I just said. It's not like, go write a policy, put a committee together. Of course, those things are important, but it's about the culture. And you don't have to wait for budget and leaders to define the culture for you. You have to define that. Your team has to define that, and decide collectively what you'll tolerate and what you won't.
Yeah. No, I love that, boundaries. And I think we are very gentle with that sometimes for several reasons. So just reinforcing that point, I think was very important. And as I think a supportive organization, obviously, like you mentioned, when the organization stands by the healthcare worker, then they also feel empowered, to make those decisions, because often organizations don't stand by healthcare workers.
Well, you know what? Sorry, just to add one other thing, right? We see a lot of times where really no fault of their own, there is broken communication, right? Yeah. Where maybe the provider in an outpatient setting says, if someone comes 20 minutes late or 30 minutes late, they have to be rescheduled. I can't upset the whole day. And that person in the front is the one responsible for communicating that message. And then that patient is there. I'm not leaving. I haven't waited for this appointment. You better fit me in. You better figure it out. And so now they're in this fishbowl, and they're like, okay, they don't feel supported to say, Mr. Jones, I need you to please have a seat. I'm being respectful to you. I will help you, but you need to be respectful to me. First of all, we don't teach them that. But secondly, they're too worried about all of the other patients and all of that stuff. So then they call the doc and they're like, hi, Mr. Jones is here. And he says he can't leave today unless he's seen. And so then the doc goes, oh, okay, well, just, you know what, put him back in exam room 4. I'll see him. The staff are so invalidated. And that just said, if you come here and you cry loud enough or you're mean enough, you're going to get your way. So, sorry, going back to that boundary conversation, I just really wanted to call that out. I think the team cohesion has to be there for us to really be able to feel supported and empowered to take action.
No. Yeah, and thank you for reinforcing that. I think I agree. and it does happen, what you just mentioned. Um, we are going towards the end. I think I have one last question, just asking about. I don't know if you've seen The Pit, but they had that scene where there was a young nurse, who got assaulted in the most recent season. And I guess for any new trainee, new healthcare worker, or somebody who's early in their career, what is the first utmost thing that they can do for their safety? And if they have gone through such an event, what would be your words of advice to them, or support, or anything like that, as we go towards our end?
Yeah, so I'll comment on a couple of phases of that, I think. We are seeing where new grads, new nurses, or new hires are asking questions in the HR interview. How are you supporting staff? What do you do to keep staff safe? What are some of your protocols? Do you have training in place? Is training free for staff? Do you support nursing away from the bedside in order to get the training? Because that's a very difficult conversation and a difficult ask for organizations. Oh, sure. To pull a nurse away from the bedside where they're earning revenue for the organization, where I have to pay more to sub somebody in for them, to pay them 4 hours or 8 hours or 2 hours or whatever it is for the training. Is that supported? Are we walking that walk? And so I think for new hires, new grads, start asking the questions early. Start holding organizations accountable. Let them know what's important to you. If you're working for an organization, get involved. Get involved. Safety is not something that you can leave up to somebody else. Like, oh, I assume that there's security, or I assume that there's a policy. It's your responsibility too. You're responsible and accountable not just for your own safety, but your coworkers' safety too. It has to be, I keep saying this, but it has to be the collective, because we could put you in Fort Knox with locked doors and card readers and all sorts of technology that makes people feel safe. But one person decides to swing the door open and walk through to go to lunch and not turn around and make sure it closes behind them. And now you've breached security for everybody. And so when we talk about safety, it's not just physical safety, it's psychological safety. And so what is being done? What are you doing? And how are you getting involved? Attend training. Don't wait for it to be mandated or your leader to tell you. You pay for a degree. You pay for education. If this is not your area of expertise, get informed, develop skill. It will create longevity in your career, and it will create safety for you to be able to stay and practice the license that you're doing. And then the one other aspect I would say is when you have an incident, when you've been exposed to violence, process it. Talk to somebody. Reach out. Don't let it fester. And, stress is cumulative. And we know that with the amount of exposures and repeated chronic complex traumas that we are exposed to, the vicarious trauma that we absorb, we have to start having true conversations around wellness and not just fluff, right? I know this is kind of the ongoing joke. It doesn't mean oh, you gave me a pizza party and now that makes me happy and engaged in my job. That's not what it is, right? I've seen best practices where we have teams of people that can activate, that are crisis responders, that they activate for staff though. Teams, free one-to-one counseling and coaching sessions embedded into the care for staff. True follow-up on reporting and actual closing the loop of what was done. People feel like we know it's underreported because they're like, nothing's going to be done about it anyway. Or there's never, even when something is done, that loop doesn't get closed. No one goes back to them to see how they're doing. And so yeah, that's time intensive, but it's investment in our teams. And so we have to start at a few of those places. I could go on forever about formalizing a program,
Yeah.
but when we're talking about where can we start, having some accountability for myself, holding my organization accountable, and ensuring and demanding that there is true support, not just in fluff and in language, but in actual action and follow through.
Thank you so much, Kim, for this wonderful conversation. I just love the work that you're doing, and just talking to you to see how passionate you are about it. I think that's so important. We need the conversation out there. We need more people like you talking about it so you can have some more clones. I'm joking. But it's just wonderful work, and I hope you continue with this passion towards it. And it was really a pleasure to have you on the podcast today. We do have a tradition to close the episode with a poem. So as we are going towards the end, I'd like to leave you with a poem, and it's by Stanley Kunitz, and it's called "The Layers." And it's a reminder, that difficult experiences can change us, but they don't have to define us. We can carry what we've been through without losing who we are. And the poem is, "I walked through many lives, some of them my own, and I'm not who I was. Though some principle of being abides from which I struggle, not to stray. When I look behind as I'm compelled to look, before I can gather strength to proceed on my journey, I see the milestones dwindling towards the horizon, and the slow fires trailing from the abandoned campsites, over which scavenger angels wheel on heavy wings. Oh, I have made myself a tribe out of my true affections, and my tribe is scattered. How shall the heart be reconciled to its feast of losses? In a rising wind, the manic dust of my friends, those who fell along the way, bitterly stings my face. Yet I turn, exulting somewhat, with my will intact to go wherever I need to go, and every stone on the road precious to me in my darkest night, when the moon was covered and I roamed through wreckage, a nimbus clouded voice directed me. Live in the layers, not on the litter. Though I lack the art to decipher it, no doubt the next chapter in my book of transformations is already written. I'm not done with my changes." Thank you, Kim, so much for doing this with us today.
Thank you so much, Saba. I appreciate it. Stay safe.